Good afternoon and welcome to our panel conversation, Aging in Place, Program Models and Community Resources. My name is Juliana Valencia and I am the supervisor for the Caregiver and Supportive Services Unit with Fairfax Area Agency on Aging. Let me begin by acknowledging that aging in place is a complex subject and there are many factors that are going to influence how we age. Most of us want to remain in our homes, in our communities, but as we get older, the odds of becoming more dependent and socially isolated are higher. So aging in place involves the planning and coordination of a variety of supportive services to help a loved one remain safe and engaged in their communities, especially when their health begins to decline. So during this panel conversation, we will explore different community models that promote social connection, health, and quality of life. A few housekeeping items before we begin today's session. Today's presentation is going to be recorded. A link to the recording of this session will be sent to all of you by next week. Now, if you have any questions during this presentation, just please go ahead and use the Q&A button. We are going to have a Q&A session where we will be addressing all of your questions. We have enabled closed captioning, so if you need it, please make sure to click on the closed captioning button along the bottom of your Zoom window. Also, at the end of the presentation, there is going to be a quick survey. Please take a moment to answer those questions. Now I would like to introduce our four panelists. We have Susan Zillman, who is the Village and Special Projects Coordinator with Fairfax County Neighborhood and Community Services. We have Sherry Parker, who is a licensed clinical social worker and team lead medical social worker with primary care at home with Capital Care and Health. We also have Mia Grigg, who is the Vice President of Integrated Care Services with the Institute on Aging, Friendship Line. And we have Sarah Papa, who is a Program Manager with Northern Virginia Falls Prevention Alliance, Marymount University. So thank you to all of you for being here with us. And now I would like to invite Mia to give us an overview of your programs. I'm gonna go ahead and stop sharing my screen so you can do that.
Good afternoon. I would like to share about the Friendship Line. Today, the Friendship Line is 49 years old this year, and it was started in 1973 by Dr. Patrick Arbor. We are accredited suicide hotline and a warm line that serves people across the country. So what is Friendship Line? We are a opportunity for social connection. We really understand the need to connect with individuals on a much more basic human level. We've seen a huge increase in loneliness and isolation in the press. We've seen payers and communities, CBOs, focusing on the effects of loneliness and social isolation across the lifespan, but really honing in on older adults and how this affects social determinants of health and overall life satisfaction and wellness. And so the Friendship Line has been doing this for 49 years. We are not a counseling service. What we do is we connect with people, we talk to them. We have over 150 volunteers across the US and 25 or so staff members. We're open 24 hours a day, and we have warm line services throughout the day, and overnight it's really crisis. We understand that some people need to reach out and talk in the middle of the night, and we also encourage folks to try whatever tools they have at their disposal to go back to sleep and to call back in the morning. So whereas we are open 24 hours a day, we really encourage during the overnight hours for people to self-soothe and go back to sleep. So again, we are all trained in suicide prevention. It is a conversation that we talk about with our callers all the time. But a lot of folks are really needing that connection to another human being. We have really seen that it can be used as a service to vent so that you get whatever is going on off your chest. And then when you speak with family or friends, you're able to relax and really be present with them. We've also found that a lot of people call the lines who have nobody else in their circle for social connection. And really that it's a human need to be able to be listened to, respected, heard, and really touched on that level. I just wanted to show a little slide of our call volume. Again, we're in all 50 states. You can see Virginia here is our 12th biggest callers state that we receive calls from. So this certainly is something that affects the community. And we are really happy to be able to continue to offer this service to folks. I am trying to unshare my screen.
Thank you so much. That was an excellent overview. Now I would like to invite Susan, if you could share.
I apologize, I'm still muted. Welcome, everyone. I am Susan Zellman. I am the county representative for the villages within Fairfax County and the Aging and Adult program. There we go. Most people want to stay in their own homes and communities when they're aging in place is a highly desired outcome. National surveys show that 90% of people over 50 want to age at home and or in their community. They do not want to live in retirement homes or assisted living facilities or a nursing home. They do not want to disrupt their lives or their children's lives. They do not want to give their pets. They do not want to lose their independence. The aging population is growing rapidly. The good news is research is telling us it is beneficial to age in place if possible, helps protect better connections, active community participation. It promotes better health and well-being, enhances recovery from illness. It reduces Medicare and Medicaid costs, and there is a lower rate of depression and higher levels of cognition for those aging in place compared to those in a nursing home. You're more actively engaged in your community. There's data showing that, and if there's more engagement in your community, you're less likely to be socially isolated. Villages are one of the ways the Fairfax County community is addressing these needs and wants. What is a village? The village is a movement started in Boston about 20 years ago. A group of neighbors decided to come up together an efficient model for aging, using their resources. There is currently a national program for the villages with currently over 300 villages across the US. The Fairfax County has 8 villages. And I put some websites here. The National Village Network supports and assists local villages. Then there's the Washington area villages, DC, Maryland, Virginia, and then also the Fairfax County villages. Villages are community-based, grassroots, nonprofit organizations made up of members and volunteers who want to change the paradigm of aging. Each village is different and reflects the needs of its members and community. They're run by volunteers and may have paid staff. So, what types of services do villages provide? Anywhere from a helping hand to transportation, but then also helping in weather emergencies, lawn work, changing light bulbs, light house cleaning. It really depends on the village and what they're doing. We have a variety of villages in the county. Some do just transportation. Others have paid staff and do almost all of these examples. Referrals, social clubs, pet care, all those things depending on what you need. Some, depending on how the villages are set up, they may be free or have a cost. So how do volunteers help? Volunteers are the heart and soul of local villages. They provide services and support necessary necessary to assist the members, provide volunteer opportunities close to home. Our volunteers are ready to help with the small and not so small things that can make a big difference in someone's life, and so that they're able to stay in home longer. And here is a list of the villages in Fairfax County and all their websites. And here's my information. Thank you.
Thank you so much, Susan. Thank you, Sherry. If you could now take over, that would be wonderful.
Good afternoon, everybody. My name's Sherry Parker, and I'm a social worker with Capital Caring Health Primary Care. You may know Capital Caring as providing hospice and palliative care in the community. And Capital Caring saw a need for medical care at home prior to hospice care, and they decided to start this primary care at home program back in 2020. So we've been around now for about 2 years. And essentially, it's an old-fashioned house calls program where the medical providers actually go out into the home to visit the patients. And it's essentially primary care, which is provided in the home for patients that are home limited. And we have a team approach. So we have a doctor on the team, a nurse practitioner and social worker, as well as a triage nurse who, just like in your regular doctor's office where you call in and you have a medical issue, our triage nurse takes those calls and is able to provide medical advice and guidance, as well as schedule appointments if there's an urgent visit needed. But essentially we go into the home, and we also can help manage specialty care, as well as follow patients as they go in and out of the hospital if they have to, or rehab. A special part of the program is that we do provide social work support. So there is, I'm actually the social worker on the team who is able to go into the homes, provide caregiver support, as well as referrals to important community resources for patients and families. The whole goal is that we want to help patients and families to stay at home and help people age in place. This is just a list of our eligibility criteria. We initially started at age 65, but found that we have a lot of adults that are 55 plus that really require these services. So we did lower the age to 55. And we have patients with all different types of diagnoses, including dementia, heart failure, as you can see, stroke, COPD. We have patients who have multiple medical issues, diabetes, high blood pressure, etc. So the main criteria is that the person has to be home limited and require assistance getting to appointments. So that can be a patient who lives at home alone and may be socially isolated, but may have difficulty getting to the doctor because they don't have friends or family and they don't drive. It can be a patient who has dementia who becomes agitated when they leave their own home. So bringing care in the home makes good sense. Of course, you have to live in our zip code area, and patients have to be willing to have a new primary care provider. So we essentially are the patient's primary care provider and can follow them at home for many years. You do not have to be enrolled in hospice or palliative care in order to access this care. So here's a little overview of our clinical services. We usually visit patients between every 1 to 3 months, depending on their medical diagnoses and what's going on and how they're doing at home. We're able to provide urgent visits within 1 to 2 days, and people are assigned the same physician as well as a nurse practitioner that works with that physician. We provide social work services. We also have 24-hour a day, 7 days a week phone access. So if something after hours is happening, they can pick up the phone and call. Our doctors and NPs also take time to keep in touch with family about changes in patients' conditions and to discuss goals of care. Another nice thing is that every patient receives a vital sign kit at the start of care. These are the zip codes that we serve. As you can see, it's a very wide area in Fairfax County, Alexandria, Arlington, as well as Loudoun and Prince William. We do accept Medicare as primary as well as Medicaid and many of the Medicare Advantage plans. And this is just a little slide of our team. So how to get started, you can call this phone number on the screen, 844-398-4720. And you can also go to our website, which is capitalcaring.org. And I will hand it back.
Thank you, Sherry. Now I would like to invite Sarah, who can talk about the Northern Virginia Fall Prevention Alliance.
Yes, good afternoon and welcome. Pleased to be here today. So my name is Sarah Papa and I'm a faculty member at Marymount University right here in Arlington. And back in 2016, Marymount University received a small grant to implement some falls prevention programming throughout the region. We worked with some of our community partners and falls prevention was identified as a need in our area. We received a second round of funding in 2018 to continue this work. And we really sort of frame it around an academic community partnership because that's what we're doing. We're working with many, many community partners throughout the region. We are currently implementing some evidence-based programs, which I'll mention in a few minutes. And then we also have the Northern Virginia Falls Prevention Alliance, which is the community health coalition arm of our work. Last week was National Falls Prevention Awareness Week, and we were very busy out in the community giving presentations. We were conducting some falls risks screenings, and we do those throughout the year, not just during Falls Prevention Awareness Week, but we're extra busy over these last couple of weeks. So I'll just lead with that. If anyone has a group that's interested in having one of myself or one of my colleagues come out and give a presentation on falls prevention, we'd be happy to do that. But again, our model is an academic community partnership, and we're working to improve the quality of life for older adults by preventing falls, which of course helps to decrease serious injury. Why do we talk about falls, right? We know that everybody falls, people of all ages fall, but we know that as we get older, the risk of a serious injury as a result of a fall increases. About 1 in 3 or 1 in 4 older adults fall every year. We know that falls are the leading cause of fatal and non-fatal injuries in older adults. We know that they can cause a serious head trauma or serious fracture in the hip, perhaps the arm, elbow, shoulder, etc., and also can cause a traumatic brain injury. Over 800,000 individuals are hospitalized every year because of a fall. And we know that there's also a significant healthcare cost to falls. We know that that average hospitalization from a fall is around $14,000. And in the United States, we spend about $50 billion, that's billion with a B, dollars on treating falls every year. We know that the number of people who are 65 years of age and older is growing, or that segment of our population continues to grow. So we know that preventing falls continues to be a very important issue. I mentioned that we're implementing some falls prevention activities. I wanted to mention that there's this website, National Council on Aging, NCOA.org, where you can go and learn about what evidence-based falls prevention programs are being offered in your area. And I'm going to talk about the 3 that we're implementing here in just a minute. But an evidence-based falls prevention program is a program that has been researched. It has been proven to be effective. And that's why, as a funded agency, right, we're implementing programs that we know work. They've been researched and they've been proven to help reduce a fall. And I'm going to spend just a couple of minutes. Some of you perhaps have heard about these programs. These happen to be the 3 that we are currently implementing. There are others. On the National Council on Aging's website, there are approximately 13 or 14 evidence-based falls prevention programs that are listed. The 3 programs we're implementing are SAIL, which stands for Stay Active and Independent for Life. SAIL is a strength, balance, and flexibility class. We actually offer it virtually now. So some of our partners are offering it virtually. And now post-COVID, some of our partners are back to offering SAIL in person. Meets for 2 to 3 times a week for about an hour. It's a traditional aerobics class that has about 20 minutes of cardio, which can also be done from a chair. And then there's about a half an hour of strength, balance, and flexibility exercises. The second program we're currently implementing is Matter of Balance. And Matter of Balance is more of a support group type program where we meet for 2 hours a week for 8 weeks. And we really talk about managing our fear of a fall. We know that if someone is afraid they're going to fall, that's actually a risk factor and it increases their chances of falling. So in Matter of Balance, it's a cognitive restructuring program where we work with the people in that group, and they really work with each other and they help each other. But we try to reframe our thoughts about falling, and we come up with strategies that we can implement to help reduce our fear of falling so that we can go back out and do some of the things that we like to do and start being a little bit more active in our community. The third program that we're implementing is called Otago. And Otago is a program that was originally designed to be implemented one-on-one by a physical therapist with a more frail person who perhaps is homebound. It's since been translated into the community setting. So we are offering Otago with some physical therapists and other trained lay leaders at some assisted living facilities and some day health care centers and some community centers as well. The bottom line for these 3 programs really is that exercise and maintaining your fitness level, your strength, some balance throughout your entire life is really important when we're talking about falls prevention. Thank you.
Thank you so much, Sarah. That was great. Now I would like to invite all of our panelists back on screen so that we can start the Q&A. And like I mentioned earlier, we are going to allocate a few minutes at the end so that you can submit your questions and we will address them. So my first question is going to go to Mia. In a presentation that you made last year, you mentioned that when working with older adults, a lot of it becomes a conversation, right? And so you added that the majority of callers present suicide ideation and very few of them have intent, a plan, or means to carry it out. You also added that people tend to panic around suicide, and when they hear it, they call 911. Then this leads to a series of events such as hospitalizations against that person's will, instead of realizing that this is an amazing opportunity for relationship building through conversation and development of trust. That actually made a huge impact on me as I was listening to your presentation. So my question is, could you talk about the training that volunteers receive to be able to manage these type of conversations and the trust they develop with their callers?
Absolutely. So again, just to reiterate, we are accredited suicide hotline, but also a lot of our calls end up being warm line calls. So when someone comes in, they often want to share about what's going on in their life, whether it be grief or trauma, loneliness, experiencing racism or, something that's very real in their life. Oftentimes that may lead to a conversation around suicide. And so that when we're talking about suicide, we really open the conversation of, have you thought about suicide? And what people tend to do is, if they get a yes, as you said, they want to go straight to intervention, like call 911, keep this person safe. And it can be, it can really break the trust. What we train our volunteers to do is to listen without judgment, and trying to break that stigma of suicide, and trying to break that stigma of, oh my God, we need to get somebody else in here to intervene. It really is a conversation. And when you take that fear out of it and you put curiosity and respect and questioning, it can lead to a fascinating conversation. We remind people that you can want to die, you can be hopeless, you can be sad, you can be depressed, you could be grieving. It doesn't mean that you're an active suicide attempt. And so really normalizing that conversation and making it okay for people to say, I'm hurting. I don't feel good. I don't know how to get out of this hole. Yeah, I've thought about suicide, but I'm not thinking about hurting myself today. And then it backs up and you're able to talk about it. So our volunteers go through a lot of training on suicide risk assessment, on safety planning, on talking, letting the caller be the expert in their lives. So what do you do when you feel this way? What supports do you have in place? Instead of me trying to fix somebody's problems, I'm trying to listen for cues of how they take care of themselves. So the volunteers go through a lot of training around how to do that, how to listen actively, use motivational interviewing techniques to really elicit more information out of the caller, and honoring that our callers are the experts in their own lives. And how do we empower that and go along for the journey and honor them in that way.
Thank you. That's very insightful. Thank you. My next question goes to Susan. So social connectedness is essential for our health and well-being, but social connection alone can't ensure healthy aging. So what happens when villagers' needs grow beyond help with grocery shopping or referrals for home services or any similar tasks?
Oh, that's part of the reason that the county has relations with the villages. So there's the natural connection with the county to be able to feed into some larger resources, but also part of being the villages catching some of that stuff early, having those connections to your community to before it gets, when it just starts getting a little bad and needing a little bit more help and not becoming a full-fledged emergency. And so having that community to help prop you up and you can decide, get what you need. And it all depends on what the village decides to do. Some villages, it depends on how it's set up in bylaws. Some villages will help with some of those things and some villages will provide resources. But it's having those connections to get those resources earlier without less risk factors. And so it doesn't get expounded.
Thank you. And I think we will talk a little bit more about the different models that some of the villages are utilizing. I think the saying goes like, if you see one village, that's just one village, right? Yeah, you've seen one. Yeah. So my next question goes to Sherry. What are some of the challenges that family caregivers and older adults face when they are trying to access your program?
So we are a home-based program. So we do use technology and email to get consent forms and things like that back. Sometimes older adults don't always have email addresses or have the ability to know how to sign forms electronically. So we do work with friends and family and neighbors, to help get them the support they need to, get those things done, get that documentation done. We also are able to sometimes go out to the home if there's a special circumstance. Myself or one of our office admins can go out and actually assist them with filling out the paperwork in person if we kind of have exhausted all other means. One of the other things is that sometimes people have had their primary care provider for 30, 40 years, and they're very attached to them. And even though they want us to come out to the home to provide primary care, they don't always want to give up their current primary care physician. And so we do have to explain to them that you can't have more than one primary care doctor who's prescribing, you know, and kind of managing your care. So we work with them, and also often we'll get in touch with their primary care physician or have a conversation. Our doctor will have a conversation with that primary care physician because we do need to reach out and get a history and medical records before we actually make that initial visit. But we do work very hard to, you know, get people enrolled. It isn't like an emergency thing because it's primary care. So it's not like a hospice referral where it's done in, you know, 24 to 48 hours. But generally, we're able to get forms filled out and get medical records and get someone scheduled usually within like 2 to 4 weeks for the first appointment.
That's great. Thank you. So my next question is for Sarah. So while I was preparing for this panel conversation, I actually read on the Centers for Disease Control and Prevention website that every second of every day, an older adult age 65 and older suffers a fall in the United States, making falls the leading cause of injury and injury death in this age group. So 1 out of 4 older adults will fall each year in the United States, making falls a public health concern, especially among the aging population. And I'm sure you know this. So could you talk about the role of fall prevention in aging well?
Sure. So yeah, your statistics, and those are just the falls we know about, right? That one in fall, because the good news is, you know, a lot of falls don't require medical attention, which is good. But again, as we get older, that risk for a serious injury from the fall does go up. And, you know, I'm glad we're hearing from villages because I know that, you know, aging in place is so important. And a fall can sometimes result in someone not being able to remain in their home. And so that's just another reason why we want to prevent that fall. Also, just loss of independence, loss of quality of life. It might mean loss of some time from work for either the person or a family member or caregiver who has to take time off of work to then care for their friend or family member who has fallen. So it's bigger than just that dollar amount that I said earlier, right? It's of course the dealing with a disability or an injury, but also sort of the snowball ramifications that could happen from the result of that fall. We know that falls are generally predictable, and we know most falls are preventable. And so, you know, part of what we talk about, in addition to the exercise classes that I mentioned, are really, you know, slowing down a little bit, paying attention to some of your risk factors if you feel that you're at an increased risk of a fall. And we always talk to people about, talk to your healthcare provider, talk to a family member, talk to your friend if you have a fear of falling, so that you can, again, come up with some strategies so that you do feel safer staying in your own home.
Great, thank you. So my next question goes to Mia. You know, we tend to underestimate how the lack of social connections is going to affect our overall health. And at times, the journey of caregiving can become isolating, especially as a caregiver starts taking on new responsibilities that are emerging. So in a lot of the times it is common for them to be completely absorbed by what they are doing, and they end up neglecting their own needs to care for their loved ones. So, and research has shown that family caregivers are at a higher risk for depression, chronic illness, and death. So how does the Friendship Line help family caregivers?
A good question. At the Institute of Aging, we have a number of different priority buckets. Social isolation and loneliness are one, and support for caregivers is also an initiative that we focus on extensively. Understanding that oftentimes family caregivers are unpaid and they're juggling other responsibilities, whether it be jobs or family, other obligations. And a lot of time family caregiving happens suddenly. As Sarah reported, the number of falls, it's all of a sudden you become a caregiver. And so you're kind of in crisis, and caregivers tend to live in that level of crisis. There's so many great organizations across the country that give education to caregivers. But the last thing that a caregiver has the bandwidth to do is go out and get education. What they need is respite. What they need is support. And so what the Friendship Line does is we're available 24/7. We are right there in your home when you need to pick up the phone and when you need to just be like, oh my gosh, I can't handle this anymore. I'm so overwhelmed. I'm filled with grief. I'm so angry, you know, and it's a way for you to get that out. You know, you can't exactly call another family member and tell them how maddening the person you love that you're caregiving for is. And we often see these very complex relationships in family caregivers where there might be an abusive relationship. And now you're there taking care of this person who you might have a complex relationship with. So it really, you know, that conversation and being able to say something in a confidential, safe space where nobody's judging you is really, really important. And so again, you know, we know that the biggest need for caregivers to support them is that respite. And so in lieu of that respite, Friendship Line is really able to provide just kind of a moment of relief for folks to be able to talk and reflect and say what they're going through.
Thank you. So we have a really good number of questions coming from the audience, and I'm quickly going to kind of shift gears and address some of those questions. One of them is actually for Sarah, and they ask about the exercise programs, and it says, can anyone over 55 plus can take these programs, or do we have to have health issues or had a fall? Is there a cost to take these classes?
So the classes are designed, and the research is based on people who are 65 and older, but anyone of any age can take these programs. They are offered throughout Fairfax County as well as the surrounding areas in various community centers, parks and recreation departments. Your AAA offices should be able to direct you to these programs. I mentioned that SAIL is offered in person at many locations, but we also have a few of our partners, including Marymount, who are running SAIL virtually right now. We also have Matter Balance is also being offered both in person and virtually. As far as the cost goes, the cost really is up to the site, right? So we train leaders in these programs, and then we want them to go out and offer the programs. Our goal is that anyone who needs or wants to take one of these programs can find one. Generally, they're low cost if there is a cost, but a lot of them is just part of a program's offering at a community center or a senior center. So if you're a member there, you can access the class. Again, we don't set the tone, we don't set the pricing. That's really up to the site, but for the most part, they're taught by volunteer leaders, some paid staff and some agencies, but mostly volunteer leaders. And so they are low cost generally.
Wonderful. Thank you so much. So my next question is for Susan. So it's very common to wait until an emergency usually happens to reach out for help. I see that a lot. When is the most ideal time to join a village or to start one in your own neighborhood?
Now, right now, because you want to start it and be active and hopefully be one of the volunteers in establishing this wonderful network in your community for when you're paying it forward. So when you do need the help, it's set up in there and ready for you. You get payback from all the things that it's a give and take. A lot of times people want to start these villages and on the younger side, and we want younger volunteers and younger board members because it is about the community. A lot of the villages, yes, most of the services are geared towards older adults, but they're the way they set up is for the community in general. And so it could be one of the villages we have it in Fairfax, they're through their neighborhood, and it's all through the neighborhood. And they have a committee of their villages that welcome all new homeowners. They bring them baked goods, welcome to the neighborhood, want to join our village. And so that way that whole neighbors helping neighbors philosophy is really important. And a lot of times when it's becoming an emergency, you're already at the cusp of where the village can't help you. You need to get much, but we could avoid that emergency by having those social connections, being less socially isolated, having those friendly calls, and so things get caught sooner, faster, and get involvement. So we're not having these grand life impacting emergencies. I mean, they are going to happen, but but the more connected you are with your community, the more supported you will be.
Thank you, Susan. And the next question comes from the audience, and it's for Mia. Does the friendship line know where a caller is from? And are you able to refer callers to local support options?
Absolutely. So we have our call center software that will pull the phone number from a caller. So you can search by area code. But we know with cell phones and that sort of thing that anyone could live anywhere. Once we connect with a caller, we do ask for some demographic information, and that's really helpful to know where our callers are calling from, and if there's a high need somewhere, and to make sure that we are reaching underserved areas, demographics, etc. But it is an option to remain anonymous. So we do ask each caller to tell us the city they're calling from, but we don't always get that information, and it doesn't get in the way of the caller. As far as being able to give out resources, absolutely. If somebody calls and specifically wants a resource, we will provide that. It's important to note that the vast majority of people who call in are not looking for a phone number. A phone number is not a resource. It's we may, if I'm an expert in a certain area, I may get into talking with the caller about how to navigate that, what the backdoor secrets are, the fastest way to enroll in a program. But it's impossible for us to know those things about every resource across the country. Oftentimes our callers are not looking to get a resource or a phone number. They're really just venting. They want to be heard. And we will ask, would you like us to look up a resource for you? And most of the time they'll say no. And let me give you a quick example about that. If somebody calls in and they say, I'm at risk of being evicted or homeless, or I'm currently homeless, and we say, oh, great, let me give you the phone number to get on your housing authority list. It's really a phone number. And it's really not a quick fix for them. And it can be very insulting to assume that somebody calling and telling you that they're homeless hasn't tried everything in their power to maintain housing or to take care of themselves. So it can be somewhat insulting to start listing phone numbers like you're going to fix that person's situation. Most of the time, what our folks really want is they're calling to be heard. And they want you to know what pain they're in, what they're going through, and to give them that respect that they've tried everything. Yes, we will ask if somebody wants a resource, and most of the time that's not the reason they're calling.
Thank you so much for addressing that question. My next question is for Sherry. Among patients with chronic conditions that are disabling, what are the effects of home-based primary care interventions when it comes to their health outcomes?
So often we find that people have fewer ER visits and fewer hospital stays. Because we're going into the home, we're really able to get a good look at the home environment and really see what's going on. Do we have somebody who has poor eyesight, and isn't able to see what medications they're taking or fill a pill box? We can order home health services. We can order nursing to go in. We can refer them for the daily pill packs that have AM and PM, so the patients don't have to fill their own pill boxes, and the pharmacy does that. Our physicians are able to order home health services, physical therapy, occupational therapy, to go in there and help reduce, fall risk, which again often leads, as Sarah had shared, to hospital stays and to ER visits. So there are so many things being a home care provider where a physician and a nurse practitioner who are going into the home are able to reduce those things. Also, things like preventative healthcare. We're able to do routine blood work, and we actually have a phlebotomist that can go out to the home to draw blood work, whereas often people aren't able to get the lab, or they just, their doctor may tell them to get lab work, but they don't follow through with that. So there are so many things that we're able to do at home to help really reduce these back and forth ER visits. Sometimes when people aren't able to get to their doctor on a regular basis, we can't manage things like high blood pressure and their diabetes. And so those things get out of control and they end up using the ER as kind of primary care because they're not able to get the primary care that they need because they're not able to get out of their home to get to the doctor's office. So it's kind of a vicious cycle.
Thank you. Are your services 24 hours or does it have a schedule?
So, I mean, we make visits just like any other primary care doctor's office. Our visits occur Monday through Friday during regular business hours. But just like a doctor's office, people can call in after hours for medical advice and guidance. So we are able, there's a medical provider after hours who answers the phone, either a nurse practitioner or a doctor who can answer the phone and provide medical guidance. If someone needs to go to the emergency room, they will give that advice, or if they're able to prescribe something or give them advice about how to kind of get through the night, and then we would make a follow-up visit the next day, an urgent care visit.
Thank you. My next question is for Sarah. What are some of the risk factors and causes of falls, and where do falls usually happen?
Great question. So we know most falls, a lot of people know this, most falls happen in the home, and in the home they happen in the bathroom for the most part. So that's why, it's nice to have someone, even if it's a friend or family member, maybe an occupational therapist. There's also companies that do this. They will come into your home and they'll go room by room looking for things that you can fix, remove, repair, to help decrease that risk of a fall. When we talk about risk factors, there's sort of two categories: things that are sort of internal to you personally and things out in your home and in the community. So the things that are within yourself, of course, age, right? Age is one of the risk factors, well, the one that we can't do much about. Having a previous fall increases your risk for another fall. And I mentioned earlier that fear of falling actually increases your risk for a fall. Things like muscle weakness, poor endurance. If you have a gait or balance problem, or if your walk has changed over time, for example. Vision and hearing issues. We always talk to people about making sure that they get their vision and their hearing checked every year. And certain medications, right? There are certain medications that can make you feel drowsy or tired, or perhaps shift your balance a little bit. And so we always recommend that people get a medication review at least once a year. Then there are those things in your home or in the community that you have to pay attention to, things like within your home, slippery surfaces, wet surfaces, throw rugs, right? Those lovely throw rugs are a big no-no with falls prevention. Or we recommend that double-sided tape around the edges of a carpet if you do have them. Clutter, hand railings and grab bars are very important within your home, within your bathroom, and on staircases, very important. We talk to people about putting things at levels where you can safely reach them in your kitchen or other places where you have shelves. And then out in the community, the sidewalks, streets, branches being down, right? We're moving into fall and winter, so we've got wet leaves, or we're going to perhaps see snow and ice in the future. So just really being aware of your surroundings. And the other thing that sort of combines both of those is not multitasking, right? We all want to multitask. We all think we're really good at multitasking, but humans are not good at multitasking. So, I talk to people about slowing down a little bit, just doing one thing at a time, thinking through, where am I going? What type of shoes should I wear? Do I need someone to help me walk across the street? just sort of assessing your situation and thinking it through so that you take maybe a few extra seconds to make sure that you're keeping yourself as safe as possible.
Thank you, Sarah. I have a question for Mia, and this question comes from the audience. By the way, please continue to submit your questions. We are going through them right now, so if you have any other questions that comes to mind, please go ahead and do that. We actually shared these slides this morning when we sent out a reminder, but we will send them again in the follow-up email. Also, you are going to get a link for the recording of this session in case you're wondering. So the next question says, and this is for Mia, do volunteers receive mental health first aid training?
We are currently not using the mental health first aid template. We have taken some of the initiatives and ideas off of that training, and they are integrated in. So not at the moment with the whole curriculum.
Is there a specific reason as to why? I know that is very popular in this area, that specific training.
Because we had created our own version of it prior to that coming out. And so we have just always continued to use our internal training documents.
Thank you.
They're very similar. It's all the same information. We just don't use their specific curriculum.
Got it. Thank you. My next question is for Sarah. How does fall prevention education fit in with the exercise and group programs?
What was the first part of your question?
So it says, how does fall prevention education fit in with the exercise and group programs?
So really with falls prevention, we're working on several things. We want to work on our cardiovascular fitness. And then for specific to falls prevention, we want to work on things like strength, endurance, balance, and flexibility. And so I do tell people it doesn't have to be one of the classes we're offering, right? There's a lot of fitness classes out there for older adults that incorporate those components. And so it's things like using some light weights, and doing some simple arm exercises, some simple leg exercises, and then practicing your balance, right? We practice standing on one foot. We stand on our right foot for 30 seconds, and then you stand on your left foot for 30 seconds. And there's some other exercises that are done in all three of the programs that really help to challenge and improve your balance. We know that if you have better leg strength, you're more likely to be able to prevent that fall, right? If I trip with my right foot, my left foot better be able to get over there quickly to prevent myself from falling. And if my legs are weak, and I don't have the strength to lift that leg and hurry up before I fall, then we're going to have the fall. So we work on strength and balance, flexibility through stretching. And then some cardiovascular fitness is also important, and people can get that through a class. They can also get that through walking. Walking also a great exercise, because when you're walking, you're balancing. So walking also a great activity.
Thank you. And just a follow-up question to this. Is this a national program? Is it available all over the United States, or is it just in this area?
So there are falls prevention efforts going on throughout the United States. Not everybody's implementing the same 3 programs that we are implementing. I know that SAIL is offered throughout the United States, as is a matter of balance. Otago, probably not quite as much as the other 2 programs. So they're not in every community, but they are being offered throughout the US.
Perfect. Thank you. Sherry, how does your program also supports family caregivers in addition to provide care for the patient?
So the fact that we have social work on the team is really a great support to caregivers. As the social worker, I'm able to go in there and meet with the patient and their loved ones and help guide them to community resources. Sometimes I assist caregivers with applying for Medicaid for their loved ones, often make referrals to the health department to get screenings done, to help people get Medicaid waiver services in place, just make referrals for people to get caregiving support in the home, often help families find respite for their loved ones so that caregivers can take much needed breaks. And also just talk with caregivers about what the options are for getting in-home help and how to best find that caregiver support that is the most helpful for that particular family, based on each situation.
Thank you. My next question goes to Susan. Susan, could you talk about some of the village models that you have seen in Fairfax?
Yes, there is the model where there is a board and paid staff, and it's fee-based depending on what is the services that are being offered, but it can be up to $600 for a couple a year. But then there's also another model in the county that does just transportation. They also have a part-time transportation coordinator, and I believe the fee for the year for a couple is like $30. So, but they only do transportation. So it really depends on what your needs are and what you want. And they're also located in two very different parts of the county. Another model is they have one in a neighborhood, just solely in a neighborhood. It's a large size neighborhood with multiple subdivisions. But they also have a small fee, like $40 or $6 a year. But they're all volunteer. It's only for the neighborhood. They do some driving, but it's limited. So it really depends, because each, like you said earlier, one village is one village, because it's not something that's set up by, say, the county. It's not set up like, let's roll out these programs, 10 different neighborhoods. No, these are community members, homeowners, you don't have to be homeowners, but like invested in that community, live there, want to stay there. And they're like, let's start this village. And the National Village Organization and the county have resources to help people start those villages. If you're interested, come see me. But it's based on what is the needs, what's the desire, what are those group of people that have come together in that neighborhood want to accomplish. And a lot of it is they do a community survey, a kind of internal, as part of the initial planning stages of becoming a village, is kind of checking out, what are we looking for, what are we missing, what are some of the gaps in this particular neighborhood of the county, because the county is huge. It's across the country too. Some of the neighborhoods across the country, villages, are set up and connected with the AAA and the area agencies, like in Colorado and Washington. It's really based on jurisdiction and based on communities and how they want to be set up. But the main thoroughfare of all of them is wanting to remain home, wanting to have more community connection, and to help each other, and eventually get the help that you may need as well. So it's really investing in your community and also in yourself.
Thank you. My next question is for Sherry. Someone in the audience asked, why are some zip codes excluded from your service area?
So right now, we've started services in 2020. And so we actually started out with a much smaller service area, primarily in the Arlington, McLean, Falls Church area. So we actually have expanded zip codes really a lot. We've expanded, much more into Fairfax County, Prince William, part of Loudoun. So we expect that we will expand more, as our census grows and as we're able to add new staff. So that is our hope. And we do cover parts of Northwest, as well as DC, as well as Montgomery County. So the hope is to grow in the future, but, right now we're providing very high quality services with a group of providers, and we're able to really meet the needs of those patients and families. So we don't want to expand too quickly. We want to make sure we have the resources and the staff support to provide really excellent quality care.
Thank you. And I think that's very important because sometimes, yes, you want to serve all of the community and everyone who comes to you, but if you don't have the people who can take care of them, yeah, they might end up falling through the cracks, unfortunately.
Right.
Yeah. So my next question is for Sarah. As an occupational therapist, how can I get involved with these fall prevention efforts in Fairfax County? Also, is there a team of physical therapists or occupational professionals who advise or assist with the fall prevention effort that are currently taking place?
The answer is yes, we would love to have you. And yes, we do have a team of folks. So you just go to our website, which is novafallsprevention.com. On there, you can join the Alliance. You can send us an email. You can sign up for our newsletter, that sort of thing. Super easy. We have a couple of faculty physical therapists at Marymount who are on our research team and on our dissemination team. I probably know of about 5 or 6 OTs who are members of the Alliance. Again, that's the community health coalition side of our work. And they frequently do presentations for us. They conduct the healthcare provider session during the matter of balances that we teach. And we work with them when we have folks who want an OT to come out and do an evaluation. We can certainly refer them out. So absolutely, the more the merrier as far as I'm concerned.
Thank you, Sarah. And we are actually at the end of the hour, and I have one quick question for Mia. How do people become a volunteer? Do you have like specific requirements, or can anyone in the community be a volunteer for the Friendship Line?
Anyone in the community can be a volunteer in the Friendship Line. And oftentimes we talk about, when you're talking about social connection, that our volunteers are as much the people we serve as our callers. So what COVID has allowed us to do is to translate all of our previously in-person trainings to completely remote. So we have volunteers across the country. And you can go onto our website, Institute on Aging, and find the Connect number, which is 415-750-4111. And I can add that to the information. But you would just fill out an application, and then we would call you and walk you through the training. We oftentimes have people coming through that have expertise in working with mental health, or nurses or retired doctors, but we also have a lot of students and interns. We have a lot of volunteers that really mirror our caller base of people who are isolated, who are lonely, or maybe are homebound and want an opportunity to connect and give back. So yeah, absolutely. We love our volunteers.
Thank you. And thank you so much to everyone who attended today's panel conversation. Especially thank you to our panelists who have shared an hour of their day with us and your expertise. So thank you so much. We hope that everyone in the audience found this presentation informative, and that it will help you plan for the future, for aging in place. And as I mentioned earlier, honestly, within 1 hour, we cannot possibly address every single aspect of it, but we are trying to bring these conversations in separate times throughout the year so that we can invite different resources, different professionals in the community to talk about what they are doing and how they are supporting aging in place. Thank you, everyone, and have a wonderful afternoon.